So the circle of Willis is at the base of the brain. Of course, we always show it like something like this. It looks like a little guy with a big alien head on or something, and which is fine. But you know, this is a three-dimensional object sitting inside of a three-dimensional space. It's not really flat like this, of course. It's you know, we have to draw it this way for purposes of 2 dimensions. In fact, I have a angiogram image of a circle of Willis, and you can kind of get an idea that it's certainly not a flat object. And furthermore, this sits at the base of the brain. In fact, let me zoom in on this first. I want to come over to this image just to get you an idea of what the circle would look like. From the this is the underside looking up at the brain. We have our vertebral arteries here. Those are the same vertebral arteries that you've been looking at. They come together into a basal artery here, and then a basilar artery, and then this circular structure zoomed up over here onto the right is the actual circle of Willis. This is the size of your thumbnail, so it's a very small structure. Once again, sitting at the base. And once again, this is kind of shown rather one-dimensionally, even though they've tried to take some 2-dimensional aspects of it. Certainly, the vertebral arteries coming up your neck and then the rest of this laying on the base of your brain. There is a curvature to this that we're not really seeing, but we'll see that in the angiogram when I get to it. But I just wanted to give you an idea of where this is. When you're looking for this, you're not looking up high in the head. You're looking low in the head, low in the skull anyway. All right, anatomy. Anatomy of the circle of Willis. Well, there's a lot going on here, as you could probably tell. Circle of Willis is fed by the vessels we're already looking at, the internal carotid arteries and the vertebral arteries. And we'll start with the internal carotid artery flow coming in. So, and these are obviously, the entire artery, yes, it's not shown, it's cut off. So this is really the very end of the ICA flow. I'm going to try to show as best I can direction of flow. The ICA is coming up. Then we have a big curvature of the ICA. The entire curvature also shown over here in the corner here. We'll look at that picture a little more closely in a second. This entire curvature is the carotid siphon. That's the whole circle, basically. Now that's divided into 4 parts. I don't know if you know what, we'll go ahead and do it. Go ahead and do that, because when you look at when you read carefully, it's going to tell you, boy, you know, where exactly you put your gate for your spectral is going to show you what direction of flow and everything. So as we're coming in, we're going to count backwards. It's the C4 section. And let's add color there. I was just thinking about the color I want to use right there. And actually, I'm going to hold off on putting those in, because the reason I'm holding off is, yeah, it's all artery, it's all red, right? Except when we're viewing this, when we're viewing a curved, tortuous artery like that, sometimes it's going to be red, sometimes it's going to be towards us, and sometimes it's going to be away from us. But let me hold off on that. As we come around, C3, C2, and then C1. So that's getting a little bit overly ambitious on our anatomy. I'm going to tell you right now, the subsections, the C4, 3, 2, 1, the A1s, A2s, the P1s, P2s. I'm not going to have you memorize those. I just want you to kind of just realize that that is something that we're going to possibly need to know in the future. So that's the ICA. It comes up and around, and then becomes the MCA. Middle cerebral artery. That direction of flow is, I'll go ahead and put an arrow here. Going straight out. So, well, we'll talk about, basically one of the locations is going to be the temporal bone. And so if you're looking from the temporal bone, this MCA is coming directly at you. It's a very strong signal. In fact, that's one of the ways to figure out where you are, is look for the strongest signal coming towards you. From here, let's just move this a little bit. We're going to see the ACA. That's not the Affordable Care Act. That is the anterior cerebral artery. Now, that actually continues on. I'm going to put actually ACA and put an arrow to here as well. That always bothered me. These guys are they're so adept at changing the names of vessels as they go, that I would think that after this branch here in the middle, that it would no longer be the ACA, or they'd have some other designation. But the only designations it actually has is this whole segment here is A1, and then up here is A2. Now, ACA, anterior communicating artery. So this is basically anterior, so going towards really the face. In fact, let me come back. I want to make sure you guys have an understanding of where this all is. Anterior. These two guys coming out right there, by the way, those are the, they go to the nose. The olfactory bulbs is what those are called. And actually, I just heard, gosh, where was it? Louisiana or something. They had a brain-eating amoebas in the water due to one of the recent hurricanes. And they said, okay, the water's safe, but you know what? try not to get the water up your nose, which I'm sure made everyone really comfortable, because what happens is if water gets up your nose and there's brain-eating amoebas in that water, it actually, through the olfactory bulbs, has a direct line of attack into your brain, which is just a fun thing to talk about. But here is, if I can point to there, ACA. And then I'm going to also add this little right there. So that's the A. The first arrow I wrote was A1. And then up here is A2. So that's going more towards your face, towards your nose. Guess I should, oh dear. Should have kept that picture closer by. Oh well. Now, one of the smallest arteries in the body is this guy. That's the anterior communicating, so C little o, artery. Anterior communicating artery. Well, and that's it for the top part. Now, the circle of Willis is not always complete. One thing I drew, and I'm kind of looking at this now, this ACA is actually a very small artery. It is a thread of an artery, unless it's being used as collateral flow. And we've already learned that you can have collateral flow going through the circle of Willis in order to feed a subclavian stele or to feed the opposite side of the brain for a occluded ICA on one side or the other. So in those cases, then the ACA, and well, I might as well mention the yeah, we're missing quite a few people, aren't we? All right. ACOA, anterior communicating artery. Back here, now we're going to start with the, well, it's actually, we're going to start from vertebrals and work our way up. So direction of flow in here was ICA through the MCA, ICA into the ACA, into the anterior communicating artery. Direction of flow back here is going to start, of course, with the vertebral arteries. Now, there's actually a lot of little branches that I did not draw. Figure 10.1 on in your image didn't draw them in either. But there, you know, there's artery, artery, artery. There's even arteries that come off the vertebral artery there. But we don't worry about those. Those are small feeders. They're feeding. Well, they're feeding back here. The first brain structure that comes into is the cerebellum. But we're not going to draw those. So the vertebral artery comes up and meets together, and this is going to be in the back of the head, kind of going from as your spine goes into your skull through the foramen magnum. is the basilar artery. I guess I should be writing more of these down. Well, I'll write more in a second. Basilar artery then splits into the posterior cerebral artery. Oh my God, I almost said that wrong. Posterior, I'll at least shorten that. Posterior cerebral artery. That one does actually have a P1 and a P2 segment. And then another tiny artery that is often not seen, or usually not seen during a transcranial Doppler, which is how we would see any of these, is the posterior communicating artery here. In fact, let me, you guys know what the ICA is, but let me add in just an MCA. Oops. And then posterior communicating artery. I won't write that one in. I don't have the room for it. So you guys will need to know. I mean, it's good to know a few things. Like I said, these P1s, P2s, C1, C, those are nice to know. It would benefit you to know these. By the way, I can't remember which hospital, probably university or something, but one of the hospitals in town does do these. I haven't seen these done since I was a student, so I'm no expert at them. I've kind of played with the transducer on my own skull. These are rare, but if you're in a hospital with a decent size ICU, in a brain trauma unit, you will see these. So it's good, of course, to know the vertebral, the basilar, posterior cerebellar, posterior communicating, which is this whole guy here. And of course, the ICA comes up and feeds mostly the MCA, the middle cerebral artery. Good to know. Oh, there's one artery I forgot. I'd say it's very good to know the carotid siphon is just the squirrely part there. Anterior cerebral artery, anterior communicating artery, which is just only this little piece right here. I did forget one artery. Let me come in because this is kind of important. Well, it's Not so important as, well, it is. We've mentioned this before. This guy right here, and blood flow, by the way, blood flow normally is going out, always the wrong color. And this is the OA, or ocular artery. We'll circle this one too. So we've mentioned that one before, and we talked about collateral pathways and how we can get a, well, it was a verbification of a word. It was internalization of the external carotid artery. Internalization of the external carotid artery. That means what happens there is the internal carotid is occluded. By the way, guys, oh, you haven't all taken that homework yet. All right, well, clue for number 4, occluded. So if the ICA is occluded, there are other ways of blood getting up that side. Well, let's just mention, of course, if the ICA is occluded and you have a nice, healthy, complete, not everyone has a complete circle of Willis. Some people are missing a PCOA, a posterior communicating artery, or the ACOA. And but of course, if let's see, well, we'll go ahead and occlude this ICA. And by the way, remember how I said with occlusion, you have to really make sure it's occlusion, because there's a big difference for the doctor's point of view, the surgeon's point of view, of an occlusion versus a trickle flow. Because what I'm drawing in here, this would not be plaque. I mean, there could be some plaque up there, but it's not plaque. On the case of total occlusion, this is thrombus. This is the blood flow just simply stopped moving, and so it coagulated. It became a thrombus. Whereas further down the line, it's actual plaque, which occluded the flow, which made the thrombus. And the reason why that's important to distinguish is because if there's even the smallest amount of blood flow making it through, in other words, we call this trickle flow, or pretty much trickle flow, making it through, then this blood is moving, and there's a good chance there's no thrombus in there, and it's a good chance that the surgery will be successful. But if this does not exist, and there is no flow at all, then you can assume the rest of the vessel is thrombused. Up until this point at the ocular artery. So yes, one way of getting blood around to the other side, to, let's say, that would be the right, well, patient's left side of the brain, would be simply to go around the circle. That's what it's there for. It's designed for this purpose, is to help the brain survive even when there's plaque or other things going on to cause blood flow stoppage. But remember what we learned about before. Now let me label a couple of things. Of course, this is ICA, oops, ECA, siphon. Oof, that's totally unreadable, but that says siphon. And then from this point of view, it's very hard to draw the circle, but the circle of Willis is basically kind of more or less in that plane of existence. That's why I say this isn't like flat standing up. The circle lays down underneath the brain. But we learned before that if the ICA is in fact completely occluded, blood can find its way through the facial artery, past the eye, into the ocular artery, and back into the circle of Willis. In that case, when you do the waveform on this guy, it's going to look like a low resistance waveform. It's going to look like the ICA because it's taking over the ICA's job. It can be very confusing. All right. So exam. Okay, let's look. I want to look at this angiogram here. This is actually pretty cool. So they have ACOM, whereas I had ACOA, but you could see it's the same thing. The A is assumed, it's all arteries in here, and they just put COM in rather than CO. But so that's a tiny, look at this tiny little vessel right there. Is the anterior communicating artery. Anterior because it's more towards the face. The posterior communicating artery, on my screen, and I have the original, I could barely see that at all, but it is there. I think on this side, the posterior communicating artery is a little easier to see, but that kind of gives you an idea of the size of those particular arteries. The ACOA is not only tiny, but it's also like a millimeter long, so not easy to find. You can see that the ICAs are quite large here coming in. And then you can see the carotid siphon. That's probably actually carotid siphon probably starts here, comes all the way around. That's the carotid siphon. It's like a fancy number 9. And then the middle cerebral artery is coming out like that. Let's see, up is down, down. Well, yeah, hard to, and of course that's going to split off as well. Oh, I didn't mention middle cerebral artery has a M1 and M2 on it as well. Well, actually, let me just write right here. M1, and then as it splits, M2. Oh no, here it is. Look at that. Bam, baby. M1, M2. Cool. We have our vertebral arteries coming up. Basilar artery. There are branches, but even the angiogram can't see them. They're too faint. The posterior posterior cerebral artery, P1, P2. P1, P2. And that's that change in direction is important to know, because when you're when you're looking at this artery, could actually, depending on exactly where you put your gate, will depend on whether or not it seems to be coming towards you or away from you. One other thing I'll mention is that most people who do this do it completely blind. They do it with a continuous wave transducer. And they know that the vast majority of people, when you go from the outside skull and you put your gate at 50 millimeters or 5 centimeters, you are on the M1 section of the middle cerebral artery. And they go in blind. This is the first thing they look for. And they just kind of sweep around at 5 centimeters, very small sweeping, until they come across this artery, and boom, they'll get a very strong waveform coming towards them, hopefully low resistance and of normal velocities. Yeah, they do this blind. You can do it with a regular transducer, like a phased, something with a small footprint, very low frequency, and you are able to get just enough sound through the temporal bone to hit the arteries, and then just enough of an echo coming back for you to actually see something. But it's very difficult. The continuous wave transducer is far superior. Remember, the continuous wave is far more sensitive. It does not have a backing or a damping layer. And so that increased sensitivity is why, you know, most people, when they do these, they do this with continuous wave transducers. And they like to show off. Let's see. Let's come down here. Just a couple of, well, 3 actually. If you guys want to try this in lab, we can. We actually can pull out that old machine. It does have one transducer on it that can kind of get in. Now, I could almost guarantee you that this is an infant. Because we never see this well. If not an infant, maybe even a fetus, although the transducer is awfully close to the head, but probably an infant. And you can see blood coming towards them. The strong signal here is the middle cerebral artery. Blood flow gets a little confused here. Let's see. This is the ACA, kind of coming this way and this way. There's so much aliasing on this side of the ACA that you really don't know which direction the blood is flowing. But the other ACA, the contralateral ACA, is clearly flowing in this direction. And so we could probably assume, if this is a healthy child, that blood is actually flowing in that direction. It's all going that way towards the front of the head. You can see on the opposite side, the MCA is traveling away, which would be expected. The PCAs are, and this is why I mentioned P1 versus P2. Back to the original Idaho. Here, I'm going to split this baby right through the middle there. You can see that blood flow is first towards the transducer and then away. Just barely away, but away enough to make that color blue rather than red. So that's P1 is towards, P2 is away. So this is all from the temporal approach, the temporal bone approach, and not easy to do. Then we have the occipital approach. Is it occipital? Or the magnum? Well, occipital bone, this occipital bone is basically back here, and the foramen magnum is where everything comes in and out of the head, really, at least as far as the spine is concerned. So we have a vertebral artery. I don't know why it's red right here, but vertebral arteries are going away, and basilar arteries going away. You might find that a little confusing, that it seems like the basilar artery is going into the vertebrals, but remember, this is an upside down image. We're imaging from this direction, so the first thing we see are the vertebral arteries, then the basilar artery, and the blood's going away from us. So we see vertebral arteries, and then basilar artery, and everything's going away. But that makes sense if you think about how we're holding that transducer. All right. We could try both of those in the lab with limited success, unfortunately, but we could try it. I don't want you guys to try this. If you ever were asked to do an ocular ultrasound, which you shouldn't be because you're not, unless you're in a specialty location, and then they'll already have the correct transducer and the correct settings, and you make sure you're on the correct settings, by the way, because your power needs to be low enough for this one not to cause damage to the retina of the eye. When we talk about the globe, that's the globe of the eye, the eyeball itself. So they're scanning right through it, and they're actually seeing the ocular artery right here. And this person was actually able to go far enough down to see part of the carotid siphon. So he followed the ocular artery all the way until it was no longer the ocular artery, and then the only thing it could be is the carotid siphon at that point. That's pretty cool. Pretty cool stuff. Ah, yes. Now you have a bunch of really great images. In fact, I'm going to go through them. And the chart, by the way, if you do these at your hospital, you will have charts. You will not be expected to memorize stuff like this. Well, you'll memorize some of it, but as far as velocities and stuff, you won't remember that. And I'll tell you, by the way, and we're getting to some of the reasons why we would do this. Let me, let's go ahead and just draw in some angles of attack. Let's see, actually, I'll use it like blue like that. So that was a chart on page 130, I'm sorry, table 10.3. And I'm going to go through the pictures here because I don't want to screw this up. Middle cerebral artery. This is what you start out on most of the time. And we're only really going to talk about the temporal approach. It's the most common approach. If you come in and you set your depth, set your depth. In other words, a continuous wave transducer, you probably are blind. In other words, there is no picture, there's only waveforms. But you can at least know at what depth you are at, where your gate is. And so if you set your gate here to about 50 millimeters, or that's the same thing as saying 5 centimeters, work it around, you will find blood flow coming towards you and of low resistance. Hopefully, it should look like an ICA because it's low resistance. You know what, I'll use a bunch of, let's get rid of my 2 little gates there. So that could be image number 1. Image number 2, going to use green here. We're going to make this we're going to move just a tiny bit. Whoops. It would help if I was using the right setting. Let's see, because you want to be over that point right there. So if we come in and set our gate here, and by the way, the gate is set fairly large. That little SV button on our machine, we open that up a little bit. Because we open it up, we'll never see laminar flow, even if it does exist. You're not going to see it because you will have the entire vessel inside of that gate from wall to center to wall, and so you'll never see laminar flow. But from this position, I'm going to remove that gate there. We have a waveform that can look a little bit like, oops. And then a baseline. A little bit like that. Now, sometimes that's artifact. We'll talk about that soon enough. Sometimes it's artifact when you have flow, arterial flow on both sides of the vessel. But in this case, it's not artifact, it's 2 different vessels. It's the MCA and the M1 section of the MCA. I'll just go ahead and I'll go ahead and write that, M1. And then the ACA, we're catching just a tiny bit of this ACA, which is traveling that direction. The ACA, from this point of view, travels away from us. So this is ACA, and really at the origin of the ACA. So we could also say A1, because this whole section is A1 though. Now, if we want to go even further, let's see. I'll just erase. That's too small. Okay. Oh, what pretty colors will we use? And so we rock our transducer, and these are very small movements. Remember, this is 5 centimeters away. Well, now 6 centimeters away. 6 centimeters? 7 meters away. Well, so by the way, the first one was 5. We set it to 5 to get just the MCA. That was the blue line. The green line, a little bit deeper, because we know it's a little bit farther away from, even just looking at the picture, we know that the intersection of the MCA and the ACA, that bifurcation, I should say, I guess, is a little bit deeper. That was, well, on this picture, 68 millimeters or 6.8 centimeters. Now we go a little bit farther, and if we want to definitively look at the ACA, there it is. And that, just to show you really quickly, is an upside down image. Oh, and in this case, we don't change that. Normally we take we always have our arteries above the baseline. This is an exception to the rule. We don't do that anymore because we need to show direction of flow. And if you're changing everything to above the baseline, the doctor's going to be infuriated because he or she can't tell what direction the blood is actually flowing. Or at least it's a lot harder to tell. So we don't want to do them any. Or we're going to skip 10, 11. Then we're just going to go straight to the posterior communicating artery. No, I'm sorry, posterior cerebral artery. You got to be careful with that because these guys, the PCOAs, these PCOAs here and here are so small that you're probably not going to pick them up at all. Or if you do, it's going to be a wisp of a waveform. Let's see, I guess I'll use an orange, burnt orange color. And of course, now we could just aim every time. Aim just back a little bit and get, ooh, well, let me do that line just one more time. Posterior communicating posterior cerebral artery, PCA1, is towards us. If you got PCA2, and I'm just going to bring it down this direction, that flow kind of backs up, and so PCA P2, the second part of that artery, is most likely to be going away from you. Vertebral artery, well, yeah. We'll go ahead, look at the vertebrals just really quick, because they're easy enough. And then we'll stop there on our directions. Well, that's kind of pretty, I like that. All right, let me just draw a quick transducer. I'm gonna have a transducer here. The reason being is I kind of want to show that this is up underneath the skull. And you get it. So our transducer is aiming up in that direction. And let's see, dark blue, purple. That can be traveling and we're along that line, You can get both. Well, you could image both at the same time, although if you're only using a gate, then you could only do one artery at a time. And you could even get the basilar artery from that point of view. So that would be the more occipital approach. All right. I'm sorry, it is called the foramen magnum approach. So there's as you know, there's approaches through the eye, underneath the jaw, the soft part of the jaw. You could actually look up. There is the loop. What's it called again? Well, there's a loop view, and that's basically, it's as if you're coming in doing the ICA and you're coming up all the way near the ear, except now you have a transducer that could handle being angled up, and you're following the ICA. You could actually follow the ICA all the way up into the brain as it travels through the skull. You could follow that up. Well, actually, let me just quickly draw one. It's red here. From that point of view, that is basically from the very edge of your jaw. You can see my face, the edge of your jaw, looking up, and it's going to come all the way. You're literally just following the vessel far more than we can with our imaging equipment. We really can't do that, but with a continuous wave transducer, you can. Okay, let me back out. What else did I have here?
And with that one, the wavelength is going to be displayed the same way as the P2 and the PCA, right?
So that would be from this, if you're coming from under the jaw looking up. So unlike with our carotid ultrasound, we would put the artery on top of the baseline. If you're looking from this direction, or if you're looking from the vertebral direction, it's below the baseline.
Gotcha. Okay, thank you.
So this is just a good picture, decent picture here of, this is much better, honestly. If I'm working in a location that's asking me to see a patient every single day, and so I did this when I was a student, and so I did a lot of them. So it's not, well, I assisted in a lot of them. These were really, the brain's kind of important, so they didn't just let me go wild on these, but I did assist and did some of these myself, and they were not easy. And even for the techs who have been there for years doing this, they're like, oh my God, let's go up and see this guy. Every day for the last month, we've been seeing this guy, and every time they go, even knowing the person, they still had to struggle to find the MCA, and then they would image the MCA. And I'm going to tell you in a second why we're doing this. It's not just for the fun of it. But what's shown here is a device that, once precisely managed or positioned, you don't have to be standing there anymore. In fact, you don't even have to have your equipment there anymore. It's just the ICU could have their own equipment and constantly monitor the middle cerebral artery. And that's usually when you're seeing these headgear, they're just on the middle cerebral artery. That's all they worry about. The MCA is probably the most important. Not only is it the easiest one to find, it's the most important. It's kind of it's the harbinger of death, as it were, the middle cerebral artery. If that's screwed up, you're screwed up. And so what happens is these people get a vasospasm. That's probably the number one reason why we do these, is for vasospasm. And not a good vasospasm, not like, woo, I'm spastic. No, it's like it's really, it's it's really a vasoconstriction, like to the max, man. Like max, I'll just put max. Like it's not simply vasoconstriction. That's what veins and arteries do naturally. Arterioles mostly, the smaller arteries, they naturally vasoconstrict. You have plenty of arteries in your body right now vasoconstricting, and some arteries are vasodilating. Vasospasm is when it constricts and shuts off, or almost shuts off. And this is usually status post-bleed. I mentioned the other day being many weeks ago, and you could have an aneurysm. Aneurysms aren't bad. That's a berry aneurysm because while it looks like a berry, and berry aneurysms, by the way, occur in the circle of Willis or very close to the circle of Willis almost exclusively in the brain. This berry aneurysm is not doing anyone any problems as of right now. It's just when it decides to pop. That's not good. And the original bleed, the blood first getting out of the brain is not what makes you pass. Well, it's not what kills you. It's blood that is intercellular blood that's on the brain, that's been there for a day or two or three, and then it starts to coagulate, it starts to break down. The breakdown products really have a negative consequences. And so usually a bleed, this stands for subarachnoid. Arachnoid is basically the brain covering. So anything below the brain or below the covering of the brain. Hemorrhage. Oh God, I hate spelling hemorrhage. Hemorrhage. Oh my God, I spelled it right. Subarachnoid hemorrhage. So with a subarachnoid hemorrhage, you get delayed ischemic. So obviously delayed, delayed means ischemic. It just means not enough blood, not enough oxygen. Neurologic deficits with an S. DINDS. DINS? I don't know. Some acronyms I don't know how to say. Mainly found in the circle of Willis or its branches. These vasospasms happen centrally in the brain. They don't generally happen out on the edge of the brain. So we do daily monitoring, and ultrasound, as difficult as it is to get through that thick skull of Max. I'm just messing with you. But as difficult as it is to get through a thick skull and all the troubles we have, ultrasound is still the best modality for the monitoring, the daily monitoring. And so, yeah, in some hospitals, you see the same patient every day for weeks on end until they start getting better. And so we'll see the vasospasm itself, it's, you're probably going to see very high velocities. If your Doppler gate is in the right spot, you can see very high velocities. You can see reduced flows, reduced volume flow for sure, if a large section is vasospasm. Now, I mentioned the other day during the endarterectomies that we need to talk about hits. Well, we got it. And not like This isn't top 100 hits or top 20 on the radio. Does anyone listen to radio anymore? This is emboli monitoring, usually during a procedure. There's a lot of vascular surgeries that can cause a stroke during the procedure, and so that vascular surgery, that's, you know, there's always a risk of bleeding, a risk of infection. Well, there's also a risk of stroke. And so during an endarterectomy, for instance, or a stent placement, for instance, you could have emboli monitoring. Now, you could have some poor tech sitting there forever, or you could have one of these. And here's a little closer. Grab this one because we can see. This is a middle cerebral artery monitoring device that is a continuous wave transducer. You're not going to get a picture. You're only going to get a waveform. Now you could see, though, that this is seems to be articulated in a couple of different directions, so that you could really fine tune exactly where that beam is heading. So hits, I have to do this from memory because it's not in front of me. Let's see. High intensity, transient, signals. Whew, got it. High intensity, transient signals. You have a picture in your book, and actually I found that same picture on the internet, and technically speaking, those were not emboli. Well, they are emboli, but they were air emboli. It was a form of contrast that we can use in ultrasound, which we talk about on Monday, I think, or at least I'll be talking and you'll be listening. But in any case, the picture is the same. That's page 147 in your book. And so, as we know, blood, let's quickly review this. Red blood cell, always the wrong color, but I'll at least make my little donut-shaped red blood cell. What kind of echo comes from a red blood cell? It's weak, I could tell you that, right? And it comes out in every direction equally. Which kind of means that most of that energy is going in the opposite direction of where your transducer is. So you're only getting a very small amount of information back from blood, which is why blood on grayscale is generally anechoic or barely seen. If the red blood cells are clumping together, you might see a little bit. And that's okay, by the way, red blood cells clumping together. This is, remember, Rayleigh R-A-Y-L-I-E-G-H. Rayleigh scattering is very weak scattering, which is why we have to use Doppler in order to see blood. But an air bubble, well, so in the case of your picture on page 147, technically those are air bubbles, but it doesn't matter. Air bubble, thrombus, piece of plaque, piece of meat, whatever is going up, whatever is embolizing to your brain is going to have a very, very strong signal. Now remember, this is down here in the middle because this is not traveling as fast as most of the blood. This is a little This is a little slow. The blood's kind of moving around it, but it's moving along at you know, let's say this is, if that's 50, it's probably moving at 25 centimeters per second. But the velocity doesn't matter. The fact that this is a very high signal means that it wasn't Rayleigh scattering that caused it. It was an actual reflection of moving solid material. Another image down here, which I thought was great. Oh, and by the way, this is fancier fancier spectral than we have. It's a color spectral. So there's actually a color map on the side here, which I'm not 100% familiar with this one, but I believe the color is, oh, I can't draw off the side, amplitude. So very high amplitudes are red, low amplitudes are green, lowest are blue. And so once again, this shows a red blip traveling along with the blood. So the reason why this is important during a procedure is doctors know exactly, well, they have a good idea of what to expect at this point. They say, well, geez, we did the exam and we only got one small hit. Probably a very successful exam. No stroke. At the most, a very small TIA, transient ischemic attack, but then no big deal. But if they have a lot of hits, then they're worried and they're going to have to really monitor that patient.
So
I just mentioned sickle cell disease. These poor folks get, they get a lot of things wrong. They get strokes. Anywhere where you have small arteries, the sickle cell, and of course, rather than a sickle cell is not shaped like but this guy, but shaped more like, well, a sickle. Not an icicle, but a sickle. That doesn't play well with blood vessels and other red blood cells. It tends to get stuck. It tends to not be able to bend. The red blood cell, the reason why it's shaped like a donut, by the way, that hole in the middle, it's not a full hole. It's not truly a donut, but it's a good dimple in the middle. It actually helps the cell fold when it needs to. And so sometimes this red blood cells will fold into a taco to make it past something, make it through something, and then pop open again. These sickle cells don't do that. And when you have a number of them all getting stuck on each other, and you might have some normal cells in the mix there too, but these sickle cells cause all sorts of problems, including brain problems, including strokes. Sometimes the other reason for doing this exam is to look for, let's see, what time is it? 10:41. Yeah, that's a short class today, guys, because I'm pretty much done. What other reasons? Collateral flow. Oh, that's right. So I wanted to talk about that. We have some good explanations of collateral flow, by the way, on page 142. Starting on page 142. If you are interested in the plumbing, let me come. I can't remember. Okay, let's just. Oh well, I did talk about the direction of flow. Okay. me just write in something though. So from our perspective, you know, blood flow is towards, it's away in the anterior cerebral artery. We don't see blood flow in here. It's just too small, usually, unless there is collateral flow. And then if you see flow in that easily, that's an indication of collateral flow. Towards, this is actually away. So P1 for posterior cerebral artery, P1 is towards, P2 is away. These guys, well, from the perspective, what do I have? Am I done with this? Well, if you image right here, it's both towards and away because you're seeing two arteries at the same time. From the perspective of the occipital approach, everything should be away from you. If one of them is backwards, then what you have is a subclavian steal, where blood flow is traveling actually through the base of the head, almost the base of the brain, in order to feed your arm, which is kind of scary. So obviously that can cause some circulatory problems. You work your arm out and you get dizzy. I don't know if that actually ever happens, but okay, so we've talked about that. I think we talked about everything I really want to talk about with this exam. Like I said, we could try this. I can't guarantee any kind of success in the lab. Yeah.
I'd be a good candidate to try it on. I don't have much hair.
Yeah, well, you and me both. There's no concerns of getting gel in our hair. So, in fact, I could plan on hitting the razor tonight anyway. So, all right. Yeah, I think we're done. So, you guys, you should have seen that the an asynchronous assignment was created. It was 20 questions. I was pretty happy with them. If anyone's having trouble getting onto, it was a quizzes. If you're having trouble getting onto that, let me know. Remember, tomorrow is my last day here this week, and I'll be available for tutoring as well. Thursday, it's only lab, right? Only lab on Thursday. Oh, I'll talk to Melissa today to see if she's gonna proctor that or not. And then Friday, I've already pre-recorded a two-part, so actually 2 videos for Friday. That is chapter 15. I'm not gonna lie to you, it's a pretty long one. So, you know, you don't have to on Friday, you don't have to watch it exactly at 10:15. You know, you can watch it when you need to, but you need to watch it. My first video ends out kind of weak. I have to describe the difference between read and write magnification, and I just kind of just drew a blank on how to exactly to describe it. So I do admit I ended weak on that one. But then we have my second video is pretty good. And then for Monday, I'm developing another video that will be disseminated, and that's wrong book. That's 16 and 17. 16 is a 2-page chapter. Well,
So you're going to be talking with Melissa about whether or not she's going to step in and teach the labs while you're gone for
Yes.
Wednesday, Thursday, and Friday.
Yes, I'll talk to her about what she would rather have us do. I think you guys need as much lab time as possible. So I'll see whether or not she's going to have time to be able to do that. I know she's doing interviews right now, so it might not, but, let me talk to her. So anyways, on Monday, I'm developing another video ahead of time. Chapter 16 is really short, and chapter 17 is not. And the concepts in 17, I'm not going to lie, are tricky. They're real tricky. Let's see. It's not that long of a chapter, actually, 17, but it's going to take time to talk about. So I don't know that I'll have all of 17 ready for Monday, but just grab some popcorn and get comfortable, because it's going to be hard. All right. Any other questions?